Good morning, friends. So the topic given to me is very specific: low myopia, low PRK, how to proceed. Now, financial interest, of course, none. Now, what is the need of this topic? Because number one is that there is a risk of ectasia because you are having a thin pachymetry, and second thing is that quality of vision can suffer. But in most of these cases, the K is not going to be below 34, and we are not bothered about this point. I have not covered surgeon preference and profession as for choosing the procedure. For example, military men, you would like to do PRK, but that point has not been covered. So what are the major differences between LASIK and PRK? In LASIK there is no pain, but of course PRK there is pain, but with newer things what we are doing like equivalent contact lens, that problem also getting over. The recovery is quick in LASIK as compared to PRK. Regression is of course less in LASIK, and ectasia chances are more. So you can say in short that LASIK is more patient friendly, whereas PRK regression chances are definitely more and ectasia is less. So you can say that this is a cornea friendly procedure. Now Randleman was the first person to understand that there is multifactorial, ectasia is a multifactorial problem, and he came with a score where he considered 5 points: abnormal topography. Okay, this we are not considering because I have been given topic like that. Low residual bead thickness. So initially the consensus was that we should restrict to 250, but now I think everybody is shifting to minimum 300 microns bead. Young age, yes, of course. So this is a take-home message one, that younger the patient, more careful are we are going to be. Then low pre-op corneal thickness, that is what the point of discussion is. There has been debate whether this is on its own as a single entity a risk factor or not, and the debate still continues. And high myopia, of course, again this is outside the topic. Then over the period we added other risk factors. If the K is more than 47, this is a single standalone risk factor. So that is the take-home message number 2, that have a look at K. Then you have to calculate PTA. PTA is the percentage of the tissue ablated, where flap thickness plus ablation depth divided by central corneal thickness, and the cutoff is 40% for LASIK. If you are going below, if you are going above 40, then that patient is not a suitable candidate for LASIK. Then there is PVA, that is percentage of the volume which you are ablating. Now over here, if we restrict the optical zone to 6 millimeters, then it's always going to be the PTA and PVA, they behave same. So the take-home message will be, for low pachymetries, always let's keep the optical zone as 6 millimeters. There are other two factors: inherently weak cornea and genetic predisposition. So the only thing what we can do is take a proper family history. Now let us take some examples by which we can make things clear. Objective is that the residual stromal bead has to be 300 and the PTA should be less than 40%. So if you have a PACI of 490 and -5 diopter treatment, you can see that residual bead thickness is 309 and PTA is 36.9. That means we are safe. Now take a second example. The moment you have a flap of 130 instead of 120, 130, immediately residual stromal bead has gone to 299 and we are in the risky area, but the PTA is still okay. Similarly, if the PACI falls down to 470, both again RSB is 289, again we are in a risky area. So it is a dynamic play. We have to calculate residual stromal bead thickness as well as the PTA and decide what we are going to do. So take-home message 5 is flap thickness. You have to be very sure of flap thickness. So bladeless LASIK would be better. And if you are doing blade LASIK, it is very important that you know your keratome well, what kind of thicknesses usually you are getting. Okay, so now in short, the take-home message is absolute cutoff for LASIK is 470 microns. Of course, this is debatable. Cutoff may increase to 490 depending upon 3 age of the patient, younger the age, higher the cutoff, flap thickness, if you are not sure of your flap thickness, higher cutoff, and diopters to be treated. Absolute cutoff for PRK 450 microns, again this is debatable. Shift to PRK if either RSB or PTA are on the borderline. Maintain optical zone of 6 millimeters and take a proper family history. So we have to keep on revisiting our concepts and ideas when we are talking to this patient, and thank you very much.